Good afternoon, good morning, or good evening, depending on where you are. It's exactly 1 o'clock. I see we already have almost 350 participants. I will wait for 1 more minute and then we will kick off. Welcome to this webinar, which is the launch of the WHO recommendations for care of the preterm or low birth weight infant. And I would like to welcome everyone across the globe in joining us. We already have 400 people online, but we're having more people joining us, but let's kick off. And we're holding this webinar to mark the launch of this guideline, and we're really excited to be holding this on World Prematurity Day itself. I would also like to welcome in particular all our panel members who are going to be speaking today. We have a stellar set of panel members. We have Dr. Vinod Paul, who is a member of the National Institution for Transforming India, or the NITI Aayog program. We have Dr. Rajiv Bahal, who is from the Indian Council of Medical Research. We have Dr. Gagan Gupta from UNICEF, and we'll have a panel discussion moderated by Professor Gary Darmstadt from the Stanford University School of Medicine, with a number of panel members, and they will be introduced as we come to that part of the program. So having said that, maybe some housekeeping announcements first. We have translation in French. For those who would like to listen to the French translation, please click on the globe, which is at the bottom of your screen. Juste pour vous informer, on a l'interprétation en français. Donc, pour vous qui voudriez suivre le webinaire en français, il y a la traduction et il y a un petit globe en bas de votre écran. As you'll see, we unfortunately don't have time for Q&A in the program today. It's very packed, but please put your questions into the chat, and we will hopefully be able to respond to them during the chat or during the webinar, or potentially afterwards. So these guidelines that we're launching today have been in the making for the last 2 years. We started this work in November 2020, and so it's very fitting that we're able to launch them now, actually precisely on this day, World Prematurity Day. And to be clear, the guidelines are for all preterm babies born at less than 37 weeks of gestation and all low birth weight babies born at less than 2.5 kgs. We need these guidelines because mortality, morbidity, and disability is still over 10 times higher in preterm babies compared to term infants. And there has been now substantial new evidence that enabled WHO to make new recommendations and to update the older recommendations. The webinar over the next 90 minutes will have 3 parts. You can see that on the agenda slide here. In the first section, we will present the recommendations and highlight what is new and describe their impact and considerations for scaling up. In the second session, we will discuss the implementation of the recommendations. We'll have a panel of family and health service providers who will discuss why the recommendations are important for them, how they will help, and what the potential challenges are. And we'll also hear about how they could be taken forward and what is needed for their implementation. And that's, of course, the most important thing, is really to make sure that these guidelines and recommendations are going to be turned into practice at the service delivery level. And the final section then is about next steps and what WHO is doing to support this implementation. So I'm now going to hand over to Dr. Karen Edmond, who is our medical officer in our department for maternal, newborn, child and adolescent health and aging here in WHO. and who coordinated the development of the guidelines. She will describe the recommendations and moderate the rest of the webinar, along with Professor Gary Darmstadt from the Stanford University. Karen, over to you.
Thank you very much, Anshu. We are delighted that we are launching the recommendations for the care of the preterm low birth weight infant today, and that they've just been published. On the next slide now, you can see the links to the publications themselves, and we'll also put these in the chat in case you don't have access to them right now. And on the next slide, you'll see that overall, we have 25 recommendations. 11 are new and 14 are updated. 11 are strongly recommended for implementation now, and 14 may be considered. That is, they're conditional because they had more limited evidence. And there's one good practice statement. There were 16 recommendations for preventive and promotive care. 6 are for care for complications for unwell babies, and 3 for family involvement and support. And on the next slide now, you can see the recommendations in bold, that they are the ones in our new guidelines. They encompass the domains of kangaroo mother care, feeding, micronutrients, probiotics, emollients, CPAP, continuous positive airway pressure, methylxanthines, family involvement in routine care, family support, education and counselling, discharge preparation, peer support, home visits, parental leave and entitlements. There are obviously other WHO recommendations for the care of the preterm or low birth weight infants, and they're in italics on this slide, and you can see them listed here. They are for cord care, for thermal care, and for other very important interventions, and I won't go through them now. On the next slide, you can see that the process included the formation of a guideline development group of experts from 25 members from 20 countries, and they met over a 12-month period and reviewed 38 systematic reviews and meta-analyses. The guideline development group made judgments and formulated recommendations based on GRADE evidence to decision framework system, and that includes the assessment of effectiveness, certainty, values, acceptability, resources, feasibility, and equity. And the next slide here shows the countries that the guideline development group come from, and also their standing qualifications. And on the next slide, please, this shows the GRADE evidence to decision framework that the guidelines used. Next slide, please. As I mentioned, the guideline development group made strong recommendations, and they've been phrased as is recommended, and the conditional recommendations are phrased as may be considered. And the actual recommendations are now presented on the next slides. And we'll just go through them, and we'll just flash these to you now. They're in the guidelines that you can see, that you'll be able to find in the links. But very importantly, now I would like to introduce Dr. Vinod Paul, who's member for Health, Nutrition, Women and Child Development at the National Institution for Transforming India, and who's co-chair of the Guideline Development Group. Dr. Paul will present on what's important and new in the recommendations and why. So over to you now to Dr. Paul.
Thank you, Karen. Good morning, good afternoon, good evening. Distinguished colleagues from all over the world, greetings from India on the World Prematurity Day. And on this day, we are launching very, very important guidelines for global uptake. And greetings also from the Government of India that I represent today. I'm very proud to say that I had association with the group. And I'm very proud to say that in the next slide, as you see, this is a work which is built on the previous insightful work that the WHO had coordinated. The last set of guidelines on part of what we are trying to do came up in 2015. And of course, the feeding guidelines came in 2011 and so on. So this is a work which is part of our continuing journey toward evidence-based care of small babies. Next one, please. As Karen said, there are 11 strong recommendations. And this is where we all need to come together. These are clear-cut recommendations which are to be scaled up in every city, every town, every facility, every home as applicable. The new guidelines are exciting guidelines related to immediate kangaroo mother care. Unless the newborn is sick, kangaroo mother care should be started immediately, and there is strong evidence to support this. Another new recommendation is use of caffeine for apnea and extubation. Family involvement as a part and parcel of the package of services is a new recommendation, strong recommendation. And also another strong recommendation is on home visits to support the family for better care of preterm babies. New evidence has emerged in relation to 7 existing guidelines, and these have therefore been updated. These relate to KMC in general, mother's own milk, early initiation of enteral feeding, duration of exclusive breastfeeding to 6 months, now very much more clarity, iron supplementation, and the use of CPAP for RDS. Next slide, please. 14 conditional recommendations have now been crystallized by the group. These need to be considered in the setting, in terms of the context and the setting. The new ones relate to the use of probiotics, emollients, the use of CPAP immediately after birth, caffeine to prevent apnea. Earlier we talked about caffeine to treat apnea, but this is to prevent apnea. And very importantly, education and counseling and peer support and discharge preparedness as we follow up the baby after acute events are over. The 6 guidelines, they were existing conditional guidelines. They have now been updated. These relate to donor human milk, multi-component fortifier, preterm formula, zinc, vitamin AD, scheduled feeding, as well as fast advancement of feeding. As I said, new evidence gives us more confidence, and the refinements in these existing recommendations have been brought about. Next slide, please. A very important good practice statement has been made by the group, and this relates to parental leave and entitlements, which would address the special needs of the mothers, fathers, and the primary caregivers of preterm and low birth weight babies. The preterm and low birth weight babies need extra support from the family, from the caregivers, and of course the health system. And here we are making a strong pitch for providing leave and entitlements to the parents. Next. There are no recommendations as of now on the use of calcium, phosphorus, and multiple micronutrient supplementation because of insufficient evidence, and that then is our responsibility in terms of creating evidence to see whether we need them, whether it is relevant or not, or they are unnecessary. So this is a set of issues on which we are not making any recommendation. Next. I'd like to emphasize once again the new strong recommendations. One is on KMC, any KMC being recommended as soon as possible for all preterm or low birth weight babies. This is an updated recommendation now in a new form. The new recommendation, immediate KMC, which I already mentioned, we need to bring this into our practice. The use of caffeine is recommended for treatment of apnea in unequivocal terms. Use of caffeine is being recommended in unequivocal terms for extubation. Strongly, we are recommending family involvement in the care of preterm and small babies, and strongly a recommendation is being made for home visits by trained health workers to support families to care for their preterm or low birth weight babies. Next. Thank you very much. I hand you back to Karen. We hope we will all work together to take forward these recommendations in every care setting for preterm and low birth weight babies. And Indian government is committed to provide all the necessary policy and programmatic facilitation and catalytic support to further scale up in India for the scale up of these recommendations in India in our programs. Thank you very much. Over to you, Karen.
Thank you very much, Dr. Paul. I'd now like to introduce Dr. Rajiv Bal, who is the Director of the Indian Council for Medical Research, and as most of the attendees today are aware, was very recently in our department here at WHO. Dr. Bal conceived the idea of the recommendations of doing these guidelines for the care of the preterm or low birth weight infant, and was the inspiration and the driving force behind all elements of these guidelines. So we feel that these guidelines are truly Dr. Rajiv's guidelines, and we will miss Dr. Rajiv very much. So over to you, please, Dr. Rajiv, for your presentation.
Thank you very much. I will not use the slides, but I'll just speak for 2 minutes. If you permit, Karen, no need to change any slides. And in fact, we can stop this so we can see everybody for a couple of minutes. So I won't take much time. So I'm particularly happy. I hope you can hear me. Can you hear me?
Yes, we can, Rajiv.
Okay, thank you. Thank you very much. And Karen, thank you very much for your kind words. Very much it is the fruit of your labor, as well as the other people in the team, Suchita, Dr. Suchita Gupta, Dr. Suman Rao, etc. So this is, and also I would say largely Dr. V.K. Paul and your guidance, and Dr. Gary Darmstadt, who was our rock in terms of the chair of the whole guidelines group. All I can say is that I feel that this is one of the most important set of guidelines that the Department of Maternal Child Health, and I think WHO in the area of newborn health, has ever come out with. For many reasons, as were just summarized by Dr. Paul. But for me, the most important thing is that the life-saving potential and the impact of the recommendations that we are making now, and the way we have expanded the use of so many existing interventions and the new interventions that have been added is tremendous. As far as I understand the data, if I take all neonatal deaths, at least 2/3 of them, according to some estimates, even up to 80% of deaths happen in preterm or low birth weight babies. And these recommendations can actually, if you implement all of these, probably can cut it at least by half, if not more, if not by 70%. So we are talking about every year saving about 700 to 800,000 lives. So having the guidelines is not enough. And of course, there is a paired guideline that is either released or going to be released. Karen will correct me, what is it called? The steroids, antenatal corticosteroid guidelines, which combined with these low birth weight preterm care guidelines, I think are a great tool for everybody if we can get behind its implementation. And all of us, I see about 840 people on this webinar, this call. If we commit, all of us, to making sure that all the babies in the world who are low birth weight or preterm receive these interventions in the way they are conceptualized, I have no doubt in my mind that that will be one of the biggest life-saving interventions that we have ever thought of. So thank you very much. Very honored and proud to be associated with this work. But kudos to the team that made it happen, and looking forward to its implementation. Thank you.
Thank you so much, Dr. Rajiv, for your wonderful words. And what I would like to do now is move on to our next speaker, who's Dr. Gagan Gupta, who is the Senior Advisor and Team Lead for Maternal and Newborn Health at UNICEF headquarters. We're very pleased to have Dr. Guggen to speak to us today. And we'll also turn off the slides so we can see Dr. Guggen. So over to you, please. Thank you.
Thank you, Karen, so much. Can you hear me well?
Yes, we can. Thank you.
Thanks. Thank you so much. And greetings to all of you from UNICEF. And first of all, on behalf of the UNICEF leadership, and I'm also joined by my colleague Louis, we would like to acknowledge WHO, its leadership, and all the technical experts who have worked relentlessly to get this much needed guidance for the program managers. The care for the preterm and the small babies actually exemplifies the SDG agenda of both survive and thrive pretty well, with 1 million preventable deaths because of prematurity and nearly 1 million baby surviving with disability. I don't think there's a better agenda which represents both the survive and the thrive components so well. Now, as we all are still grappling to counter the strong headwinds from COVID and fast approaching the midpoint for the SDG, it's important we change gears and shift the focus from global advocacy to country actions and use all this program guidance to actually do the program implementation and bring the change on the ground. Now, this brings us to the question, what will it take to scale up the care for the preterm babies? Now, if you look at the current landscape, there are three major challenges which we find, besides the lack of sustained investment on this particularly important area. Firstly, the current efforts are very piecemeal and not in synergy and synchrony. A lot of these things are like buying the equipments for the care of preterm babies, doing some kind of a capacity building. So we need to move from this piecemeal approach to more systematic approach. The second, and if you see even the country examples, most of the countries who have done it, like India, Bangladesh, Sierra Leone, Malawi, they have learned by doing it. So it's important that we capture these experiences to help other countries so that they have a smaller gestation period from pilot to scale up. The second important thing is this being a relatively new area. It's pretty new for the program managers, both in the government as well as in the partners. Unlike antenatal care, postnatal care, which we have been doing for several decades. So it's important that we make those investments to build the capacity of our own program managers and the program managers in the government. And that's why the implementation guidance which will be coming will be very important. The third important thing is the fragmentation between the community and the facility. It's not community or facility, it has to be a seamless care from the facility and back follow-up to the community, because otherwise we won't get the maximum benefits. Now, having said this, what are the key 4 or 5 opportunities which we have to push action? So the first important thing was the target setting. Once ENAP had a dedicated target for district level coverage, it was a very big opportunity and a clear guidance to countries what needs to where they need to go. The second important thing is to define the components of a generic model which can be implemented at the district. And now we have clarity on that. There was a global consultation which was organized last year, and we had agreed for 10 critical components for scale up. And the 2 most important ones are having a national plan in place. It's a journey. We need to know where we are starting and where we need to end. We may not achieve everything in first year, but we need to know where is the end point. And second is ensuring adequate financing. It may come from the domestic resources, it may come from partners, or it can be a mix of both. But what is important is there should be a clear transition plan from the partner funded projects to donor funded to the government funded scale up. The third important thing is to have the implementation guidance, and I understand that WHO will be working on this in the coming year, which will be very important. Fourth is the integration of the newborn component in the EMOC revised framework. The EMOC framework is undergoing revision, and previously the N component was just restricted to neonatal resuscitation. But now it will include the whole care of preterm and the signal functions around the care of preterm, which will be a major shift and which will be very helpful to be used at the country level. And lastly, my colleague Louis is there, and she has been championing the investments on oxygen to be used to strengthen the district health systems, because so much investment on oxygen has happened around COVID. investments on infection prevention and control, the laboratory strengthening, the WASH strengthening. So all these opportunities which have happened because of COVID, we need to make sure that we can use them for more for the preterm care of the babies. And that's it from our side. And thank you so much. And let's move more to action and let's synergize all our efforts and resources towards it. Thank you.
Thank you very much, Dr. Gagan. And yes, definitely, let's move on to action. And pleased to report we're doing very well for time. We're aware we have a number of speakers and we're about to move to our panel discussions. So I think we can definitely allow time for our panel discussions to go on well. So now I would like to introduce Professor Gary Darmstadt, who will moderate the panel discussion. Professor Darmstadt needs no introduction to most of us. Professor Darmstadt obviously hails to us from Stanford University. So over to you, Gary.
Karen, thank you very much. I'm really honored to be here. I'm excited to introduce our panelists. We have a fantastic panel for you. We're going to hear from experts who are involved in the development of the guidelines, including guideline development group members, and also other external experts who are family representatives, researchers, and health service providers. We're going to focus our discussion on strong and primarily new recommendations. We're going to talk about why they're important. We're going to talk about how they help preterm or low birth weight infants, their mothers, and their families. And we'll hear about how these recommendations can be taken forward and what it's going to take for implementation. Our first panelist is Mrs. Silke Mader. She was a guideline development group member. She's a parent representative, and she's a parent who had twin preterm infants, one of whom died. And so when she speaks of the importance of keeping the mother and the baby together, she speaks from profound personal experience. She's chairwoman of the executive board of the European Foundation for the Care of Newborn Infants, and this was the founding organization of World Prematurity Day. Silke is going to talk about the family involvement recommendation. Silke?
Gary, I'm aware we're a bit ahead of ourselves, so Silke may not have rejoined. That's one thought. So we may be best to move on to our next speaker, and we could come back to Silke.
Okay, great. So we'll come back to Silke, and Carol, we'll come to you now. Professor Carol Kenner, also a guideline development group member. She's a neonatal nurse, and she's the Chief Executive Officer of the Council of International Neonatal Nurses. She will also talk about the family involvement recommendation. So Carol.
Thank you so much. It's an honor to be part of this group, and this has been a passion of mine for all my career working with families. My own research has been focused on transition from hospital to home, so I've done the work with families in the unit as well as following them into their homes. And I am so excited and thrilled to see that the recommendations involve parent involvement. I think we've lost some ground during the pandemic where there was so many times that families were separated from their infants. And so these recommendations, I believe, couldn't come out at a better time to reinforce the evidence that we have to support why we start and need to start in the neonatal intensive care unit or in the special unit to take care of the family as well as the baby, to involve them and realize that they're not visitors, they are a critical part of the healthcare team, to get their insights of what they observe about their baby always surprised me and encouraged me to then make this a team effort to talk about what expertise I brought as a nurse and what I could teach them, but they taught me so much. And I think sometimes we forget that. So also doing the home visits as part of the guidelines recommend, are really important, because when I would do home visits, and when some of my colleagues now do home visits, you find that the parents are scared. They still feel that they didn't learn enough, or they weren't involved enough to feel comfortable in taking that baby home. And I hate that feeling for families, and feel that it's incredibly important that we support families in making that transition home by starting from day one of the special care, to recognize their clear role and recognize them as part of the healthcare team. I think that these guidelines go a long way to support the fact that we need more family leave support, to really encourage that family unit to be a part of this new transition for them. And so again, really see great strides in having the parent involvement, having involved and recommending that we support with parent education, with encouraging them in shared decision-making in these guidelines will go a long way. What are the challenges and how do we go forward? I think it has to be encouraged to be part of all of our training programs, that families are a part of our healthcare team. We have to encourage this as we look at our units, and making sure that we are really involving the families. And then, do we have the resources? And this is a huge challenge, I think, especially coming out of the pandemic. Do we have the resources to provide those home visits, to provide the training for the people that are going out for home visits? And if we don't have the resources right now, what is the next step? Whether it's, how do we stay involved so that they get really good follow-up care? And when I say that, I mean the family unit as well as the baby. So again, I really support these guidelines, think they're a great step, but there is a lot of work that still needs to be done. Thank you.
Carol, thank you very much. And thank you for reminding us of the importance of this partnership between healthcare providers, nurses, and families, that were side by side having the same goal of taking care of the newborn. Silke, I had introduced you, but I'm going to briefly introduce you again. Silke is chairwoman of the executive board of the European Foundation for the Care of Newborn Infants. She's a parent representative, a parent herself who had twin preterm infants. And she represents the founding organization of World Prematurity Day, which brings us all together. So Silke, talking about family involvement.
Yeah, thank you so much for having me today, and also apologize for the delay, but I'm jumping from to different events, and because of founding this day. Well, first of all, I have to tell you, it means a lot for me and also our whole parent organization community that parent representatives were involved in the development of these guideline processes, but also in talking today. And this really means a lot for us, and the importance of family involvement in the care of our babies. And I would also say a big thank you to have me here today. That means a lot. I myself had an experience 25 years ago, and as parents, we were not all involved in the care of our son, Lucas. So we had visiting hours, 3 hours in the afternoon, which means for my husband going back to work, it was a problem even to see him for once a week, and sometimes even once every second week because of this visiting hours. This made it really a big challenge also in our own relationship, in the way how we feel as parents. Skin-to-skin care was provided only a few hours per day, and this also only for one of us. And it started after 1 month after our twins were born. Breastfeeding or expressing the milk was not supported at all, and so therefore I lost most of my milk. I even felt sometimes not as being the mom of this child. I sometimes thought it was the nurse who was the one who, it was her child. Parents are parents, and parents are no visitors. So I'm sure you can understand why it means for me and personally, but also for all our parents and parent community, really a lot that in these new guidelines, it's mentioned that the family should be involved, that the family should be supported. And we also will hear later today from Sally in this panel why parent support is so essential to us, and also for the long-term outcome for the child, but finally also for us. Active family involvement means that we become the main caregiver of our child. Skin-to-skin care should be provided from the moment of birth to ensure the bonding process and to be able to provide mother's own milk. If we really want that parents and especially the mother is able to bond and the mother is able to breastfeed, we have to ensure that the parents have access 24/7, and especially the mother, because she will lose her milk when she is so stressed, and when she has not access, the milk will also not flow. We cannot become self-confident, and we also can not feel that competent that we go home with this child when we are not part of the caregiving team. It is extremely stressful and also painful for us to be seen as visitors and instead of the mom or the dad of our own child. Family involvement is so important to ensure that our babies not only survive, but also thrive. And this is important for the whole family. So I also want to share that during the pandemic, and it's still going on, I mean, the pandemic is not over, parents were separated all over the world from their child. And this still happens worldwide. One parent or one family in 5 are seeing their baby at discharge. So how should bonding take place? How should the milk flow? And we all know how big the evidence is. And our research project have shown that this really needs to change that parents are separated and parents are involved in the care, that this is evidence-based. So therefore, these guidelines are helping parents all over the world to be involved in the care of their small and sick babies. And we hope also that it gives the healthcare professionals better argumentation to implement this into practice, to argue about maybe healthcare professionals and colleagues who are against it, or administrations who are blocking in the end the visiting or the welcoming policy of a unit. Thank you so much.
So, okay, thank you for so beautifully describing the importance of this recommendation and the critical role, the central role that parents play during this stressful time. Thank you. We'll next hear from Professor Suman Rao. She's a neonatologist at St. John's Hospital in Bangalore, India. She supported the WHO Secretariat in the process of developing the recommendations, and she's going to discuss the recommendation on kangaroo mother care. Suman.
Thank you, Gary. And I'm very happy to talk on the recommendations on kangaroo mother care, because I've been working in this field for the past now almost 25 years. There are 3 major changes what we see in any KMC recommendation. KMC has been a strong recommendation earlier, but the main changes, the first one is that now it is recommended for all low birth weight or preterm infants and not only infants less than 2 kgs. I'm very happy to see this change because in my work experience, we have been practicing it. 15 years ago, we had a small thesis of a postgraduate in our institute, which showed that kangaroo mother care reduces hypothermia more in the larger babies, between 2 and 2.5 kg, because they are not in a controlled environment in the NICU. They are in the postnatal wards. And therefore, since then, we have been practicing kangaroo mother care for all low birth weight infants. As a PI of the scale-up KMC study, though the study was restricted to less than 2 kgs, in our district of Koppal, we practice kangaroo mother care for all low birth weight infants, and I'm very happy to see this change. Of course, this means a big change in the way we cater, because it is going to bring up more and more babies who need KMC. So we need now the system to change to practice kangaroo mother care, not only in the NICU, not only in the KMC ward, but even in the postnatal wards. The second change that we see is that Initially, KMC was recommended in the previous recommendation for only babies who were born in the health facilities. Now it is for all babies. Now this is extremely beneficial because we know that home births still happen in many countries. And now by recommending that babies who for whatever reasons are not shifted to the hospitals, we are going to provide them this life-saving intervention, which has so many benefits. We are going to be expanding this coverage to a large section of the low birth weight infants who will benefit from it. Now, the implications of this is we need to now train all our community health workers to support kangaroo mother care very well, so that they can go home, do the home visits, and help the mothers continue kangaroo mother care even at home. The third big change that we see now, which is again a very welcome change, is that now we have defined the minimum number of hours that we need to give KMC. The recommendation early said that as long as possible, but now it is at least 8 to 24 hours because we now have evidence that at least 8 hours is needed to show all the benefits of kangaroo mother care. This is not easy. From my experience of implementing kangaroo mother care in the Scale Up KMC study, there needs to be a lot of changes to facilitate it. First and foremost, I think it's important that we welcome the mothers into the NICU. Even now in many SNCUs and many NICUs, though we have a policy of, say, family participatory care in India, mothers do not have unrestricted access to their babies. They are made to come to the doorstep or maybe to the feeding corner and give some amount of KMC and go. But now with these recommendations, we need to welcome the mothers, make them feel that yes, they are the caregivers for the baby and they're not just onlookers. And here the main area where we need to work on is all the health personnel, because they need to make the mothers feel welcome, make the changes so that the mother can spend as long as possible with the baby in the NICU. So these three changes in any KMC, I see them as quite revolutionary in increasing the coverage, not only to more number of babies, but also improving the effective KMC and thereby the benefits of kangaroo mother care. Thank you very much.
Suman, thank you very much. This makes the importance of this recommendation really clear, and thank you for also outlining some of the health system responses that are required. I understand that our French interpreters need us to speak just a little bit slower, so I will try to do that. Next, we will hear from Professor Abunalua Adejuibe. She was an external reviewer of the new guidelines and a WHO immediate KMC study group member. She's a neonatologist at the Obafemi Awolowo Hospital in Ile-Ife, Nigeria. She will talk to us about the immediate KMC recommendation. Ebun.
Yeah, thank you, Gary. I feel the simplest message for IKMC is that as soon as a preterm baby is born, they must be put into skin-to-skin contacts with their mother, no matter where they are born, either in the facility or at home. And this includes during transfer within the hospital from ward to ward, or from home or community to the hospital. In addition, the new recommendations say that this applies to unstable babies unless they are critically ill. That is for the very first time IKMC is recommended for the unstable low birth weight baby unless they are critically ill. Mothers who would otherwise will have been mere observers and feeling helpless to care for their sick new baby cannot be active partners as God has divined it from the beginning. Though initially, I must say, I was also concerned about how mothers would feel about providing KMC for their sick babies with respiratory distress. But I can recommend boldly, because I've seen it done in my ward and my colleagues' ward, that it does work. Of course, this will require that careful training and support of health workers is also put in place. In health facilities, there must be some changes to care for the baby who also needs respiratory support. This is very important because so many preterm babies have problems with breathing, and health personnel, they need to be specially trained in ensuring that KMC is provided without compromising safety. The baby will need to be positioned well with a cloth so that the airway and the respiratory support devices like props are well visible and that is not compressed. The baby needs to be fed throughout the time they are in KMC. The baby also needs quality monitoring during this period. And for health facilities with special newborn care units or those with NICUs, they will have to convert this to mother newborn ICUs. This will require much larger space to accommodate adult beds and examination couches or rooms for the mother. And policies to allow the other family members and carers into the ICU, as Suma has just said, are also necessary. The obstetric and neonatal teams will have to work much closer than they used to do. And also the obstetricians have to come there for a round in the MNICU so that the mothers are properly taken care of and they are not disadvantaged because they are in the NICU. Additionally, the NICU nurses, who are very important, must also be ready to take care of both the newborn and also their mother. Thank you very much. Happy World Prematurity Day.
Thank you, Abun, for so well illustrating the responses that were needed within your hospital to keep the mother and the baby together and to effectively implement immediate KMC. Now we'll hear from Professor Karim Manji. He was also a Global Guideline Development Group member. He's a senior pediatrician and neonatologist at Muhimbili National Hospital in Dar es Salaam, Tanzania. He will discuss some of the new feeding recommendations. Karim.
Hi, thank you very much. Can you hear me? Yes. Thank you very much, Gary, for allowing me to speak about the feeding recommendations. These guidelines, as you all have said, are very, very important. And to me, these recommendations provide the much needed evidence-based explanations to doctors, nurses, and families that mother's own milk can be given immediately after birth. Immediately after birth. And this means that we don't have to delay, like what we have the fear of delaying giving mother's own milk for whatever reason. And we have seen in Tanzania that only 40% of all the newborn babies are fed within the first hour. These are specifically for preterm and low birth weight infants. But here, the recommendations after all those evidences show that you should not delay mother's own milk. Mother's milk is life-saving, and it is better for baby's health than formula or even IV fluids for maintaining glycemia. Often this is done for the undue fear, even with mother's own milk. There is undue fear of necrotizing enterocolitis. I term this fear as necrotizophobia. There is so much necrotizophobia that we actually starve these babies. Mother and health workers should not delay feeding mother's own milk, and it should be fed as soon as possible. It is also very important for the doctors and the nurses, and in my hospital where I work at the Muhimbili National Hospital, to know that you don't have to give only small, little, tiny amounts of feed to the baby. Just like, okay, just give a trophic feed, just wipe the mouth with colostrum. No, the babies are able to receive full feeds and tolerate all the milk they want. There is evidence to that. We don't have to start them. We can start immediately to achieve full feeds as soon as possible for 30 mils per kg per day without any danger, thus allowing adequate growth and metabolism. this will make the baby stay longer with the mom because the mom is taking more time to express the milk and therefore more closer to the baby. And whatever any KMC you get is again going to multiply the benefit of mother's milk. Therefore, when these babies stay longer with the moms, the nurturing care is so important. And therefore it coincides, it overlaps with IKMC and KMC. At the Muhimbili National Hospital where I work, mothers can express breast milk and we can feed them by cup or nasogastric tube. But currently there are no resources for donor human milk. And instead we have to resort to providing infant formula if the mother's own milk is not available. We have at times facilitated for mother's own milk to be available if the mother is not well to climb up the stairs to come to the neonatal unit to have a scheduled feeding. And therefore, we sometimes store this for some mothers, which will allow these mothers to rest at night if they are unwell or if they have gone into a medical procedure. So we have that facility. But I think it should be made more available so that more of mother's milk is being given there. These new recommendations are going to give us, the doctors and nurses, particularly the doctors, and many of them are listening to me here, and I've seen them in the chat. Thank you very much for joining. It will give us an additional drive and a firepower to convince the hospital managers about all these things we have been talking for the last couple of years to implement donor human milk in the facility, so as to allow those who can't get mother's own milk to get donor milk. As I always say, human milk is for human babies, and cow's milk is for the calf. Maziwa ya ng'ombe ni kwa ajili ya ndama. Cow's milk is for the calf, the baby calf. Also at the government level, I think it is very important, and I can see some government officials here. It will be very easy for me to explain the policymakers about the importance of providing the right facilities for mothers to breastfeed and to provide donor milk. I'm sure the government policymakers have joined this webinar and will help advocate all along with us and other stakeholders the implementation of breast milk for good growth and neurodevelopment. In our own recently concluded study, The Life, with a relatively healthy babies between 1,500 to 2,400 grams, we found that those who did not regain birth weight in the first 2 weeks of life had neurodevelopmental delays, which were there seen at 12 months, and then it extended up to 24 months. So here we have this recommendation to give mother's milk as soon as possible, as much as possible, and faster and longer time. For good growth, neurodevelopment, to have a thriving, a better quality of life, a child who is not a liability, a child who is brilliant, and therefore to have our thriving preterm and low birth weight babies grow as a future of the nation. I think there are a number of things in these guidelines, and I would really appreciate all my colleagues to thoroughly read this so that we can implement this. Thank you very much. And thank you, Stigler, for the initiating of World Prematurity Day. Here we are, the World Prematurity Day, then the purple t-shirt. Happy Prematurity Day, all of you. Thank you.
I love your shirt, Kareem. Thank you so much for well illustrating the importance of mother's own milk. And you drove home a really important point about the use of these recommendations to drive policy change in countries, which we're looking forward to hearing about how those conversations went. We also have some extremely exciting new recommendations that address breathing difficulties for preterm infants. First, we're going to hear about the CPAP recommendations, and we'll hear from Professor Mohammed Shahidullah. He was a GDG member. He's a senior neonatologist at the Bangabandhu Sheikh Mujib Medical University in Dhaka, Bangladesh. He's worked for over 30 years in improving health services for newborns in district and tertiary settings. Professor Shahidullah to talk about CPAP.
Thank you. Thank you very much, Gary, for your kind introduction. As I have been given the task of talking about CPAP, and we all know that as we are observing today, the World Prematurity Day, one of the major complications or illness that the preterm babies have is respiratory distress. So when I talk about CPAP, most of us will know about it.
Amazing.
But again, I would say that it stands for continuous positive airway pressure, and it is given to the sick babies into the back of the baby's nose, which provides air pressure, which does the inflation of the lungs and helps them to breathe. So that is what is a CPAP machine is, or CPAP service of giving oxygen to the babies. The guidelines suggest or recommends that the CPAP service should be provided to all preterm babies with breathing problems. And we can actually offer this service at the special care nursery, which are either located in the district hospital or in the tertiary level hospitals. The second recommendation, which is very important and crucial, when we give CPAP support to the babies, it has to be as early as possible. What do we mean by as early as possible? That means as soon as the baby develops breathing problem or shows signs of breathing problem, CPAP has to be introduced. So we can't wait for that. If we wait, actually we are going to miss the great opportunity, because the guidelines have shown that if we do this at the very upfront, the babies will have a better survival. The other part of the recommendation is that the CPAP should be the first choice rather than mechanical ventilator. Why so? Because CPAP causes much less lung injury than mechanical ventilators. And it is as good or even better at providing the breathing support that is needed by the baby. It is also important to say that we have a new recommendation for using bubble CPAP. And what is that? It is a new device, simple, low cost, and it provides sufficient airway pressure by bubbling the pressure under the water. With care, this bubble CPAP can be set up in all district hospitals, even in low and middle income countries. Also, it is important that CPAP is now the first choice for treatment for any preterm infant with respiratory distress, not oxygen, which is now being practiced in many hospitals. I think in Bangladesh, not only, other countries as well. But when we talk about oxygen, if we cannot provide it in a safe way, it can be even injurious. It can lead to ROP, it can lead to chronic lung disease. So therefore, it is a better choice of CPAP rather than just oxygen supply, as it is being practiced in many places. Let me share with you some example in Bangladesh. In Bangladesh, we have so far established 59 scaners across the country in the public health sector. And these are supported by some of the development partners, but eventually these are established and endorsed by the government in those public hospitals. These new recommendations, which we have seen in this guideline, is going to help me and my colleagues to advocate the government to provide more CPAP machines, and also to ensure funds for ongoing training to ensure quality of care for the preterm and low birth babies who need help with their breathing. When I come to the close of my recommendation, my deliberation, I'd say that when I talk about CPAP machine, one thing has to be tapped. One is the quality equipment. This is very important because the quality equipment will give effective breathing support, and it will be safer. So therefore, if any indigenous or locally made bubble CPAP machine are there, unless it is being approved by the regulatory body, I would say that we should refrain using them. And lastly, I would emphasize about the healthcare providers training, because if they are not trained to identify babies with RDS, then it will be a problem. Also, to ensure CPAP machine in place and don't injure the nose or face. So therefore, at the very end of my deliberation, I would say careful ongoing monitoring of the preterm infant is very, very crucial. And if we can do that, we are going to really benefit our very precious preterm babies who are having breathing problem and need very support. With that, I will pass it back to Gary, our moderator. Thanks, Gary.
Thank you so much, Professor Shahadullah, for illustrating so well the different ways in which CPAP is now being recommended and some of the requirements of the system to support that. And congratulations, Bangladesh is doing an amazing job with your leadership and others in introducing and scaling up this life-saving intervention. So thank you very much. I now would like to introduce Dr. Shabina Arif, also a GDG member. She's professor at Aga Khan University in Karachi, Pakistan. She's going to talk to us about methylxanthines and particularly caffeine for stimulating breathing in preterm infants. Shabina.
Thank you, Dr. Gary. It's a pleasure and an honor to be here and to be part of this process of the WHO guideline recommendation, and what a day to do it on the preterm day. So congratulations to everyone and all those who are with us today. I'm going to talk about a condition called apnea of prematurities. Now, these small preterm babies, they tend to forget to breathe. And when they tend to forget to breathe, they go into a state where there may be oxygen delivery to the brain can be hampered. As a result of which, these babies may then develop neurodevelopmental challenges later on. So this condition in newborn babies in the preterm is called the apnea of prematurity. And I'm excited, super excited, because I am unable to, when I was a resident, and we didn't have any protocol, any form of guideline to look after these babies. And we felt it was agonizing to put them back on machines, on ventilators. So it's really good, and it's really exciting that we are now actually here and talking about what should be done for apnea of prematurity, and WHO has worked hard to bring about this recommendation. Now, this medicine is called, it's a special medicine, it's called methylxanthine, and it's very effective to control and to stop apneas in preterm babies. We not only have a recommendation now that it can be used in small preterm babies, but in addition to that, now we know we can actually use this medicine to extubate the babies successfully, meaning that these small babies, when they put on respiratory machines called ventilators and with tubes, breathing tubes inside them, we can actually use this medicine before extubating them or before taking them off the ventilator. Now, this is very important because this is the period when we are trying to extubate a baby, taking the baby off the ventilator, that these small babies tend to go into prolonged apneas, and they actually, they stop breathing. And then subsequently, they have to be put back on the ventilators and on these machines. So now we can use caffeine, the methylxanthine, in order to prevent this from happening and also prevent further lung injury, as Professor Shahidullah mentioned. The best methylxanthine that is available is caffeine. Why do I say it's best? Because it does not require any blood monitoring. It is, and hence it is not painful. So, we don't need to prick these babies. And as a result of which, both the baby and the family are happy, because it is not only difficult to pick these small babies, but it also has an implication to the cost. So caffeine, you do not need to monitor. It is friendly, and it saves a lot of finances. And I speak so because Pakistan being a low middle income country, every impact of cost has an implication on the newborn baby and the family. The best methylxanthine, as I said, is caffeine. And it's good that it is caffeine. WHO has recommended caffeine. because like any other methylxanthine like theophylline is something that we have used while we were in training, and we know that these babies had to be pricked and their blood level needed to be monitored. However, with all the good things about caffeine, there is a major issue, and the major issue is related to expense. It is expensive, it is not accessible, and therefore it tends to be a major sort of a hurdle to upscale it and to improve the coverage of caffeine for preterm babies. And especially in countries like ours, where we know the rates of prematurity are very high, however, our resources are limited. So hence in small secondary hospitals, in district headquarter hospitals where majority of these preterm births take place, this medicine, caffeine, is rarely used. We're hopeful that with the WHO and UNICEF, and I'm so happy that UNICEF is also with us in this very important and crucial guidelines that we are sharing with everyone today, that they will help to improve the supply chain for caffeine, and that it will be one of the major output of this guideline process. Caffeine is a very friendly drug. It is available both in oral form and in intravenous form, and can be given to a baby with a small syringe or a dropper, and the baby can be given by the medicine by mouth, or if the baby is on a ventilator or on a CPAP, it can be also administered through IV. So with keeping in view that caffeine is an extremely important medicine, it prevents apnea, and therefore it prevents neurodevelopmental problems that may occur later. It prevents these babies to go on respiratory support. And when it prevents babies to go on respiratory support, we are actually reducing their stay in our small NICUs or nurseries. And hence, it has a cost implication both in the public sector and also in the private sector. And it also reduces the burden of sepsis. The more we keep these preterm babies in the neonatal units, the more we are likely that it's likely that these babies will have infection. So with this, I'm hopeful that caffeine, hopefully now that we have a guideline, will be available and the supply chain will improve, and we will be able to provide caffeine to all those babies who deserve to get them, to stop apnea and to prevent them from being ventilated. With that, I would like to thank everyone, and thank you, Gary, and over to you for further moderation.
Thank you, Shabina, for so clearly explaining the uses of caffeine that we're now recommending, and also the importance of addressing the cost and the supply issues that remain a barrier. Now we're moving to our final panelist, Professor Zelly Hill. She was also a GDG member. She's Professor of Global Health at University College London. Like Silke, she's the mother of a preterm baby. She's going to discuss the family support recommendations, and she's joining us by video. So we'll turn to Zelly.
I am delighted to present the recommendation that families of preterm or low birth weight infants should be given extra support to care for their infants, starting in healthcare facilities from birth and continued during follow-up post-discharge. Today, I'm talking to you not just as a researcher, but also as the mother of a preterm born 10 years ago this week at 730 grams. Looking back at the months of hospitalization, I can vividly remember the times that I did and did not get the support I needed. Support to feel seen and acknowledged as a parent in relation to my well-being and how to care for my scarily small baby. I was lucky. I was able to ask for, access, and organize advice and support, meaning that I did KMC. I sung and read with my baby every day. I found out how to comfort him and read his cues, and I was supported in how to express and breast milk feed and giving my baby his first bath. When we were discharged, I didn't know what I was meant to do, as my baby was still tiny. I tried to recreate the routines of the facility, even making my own charts and purchasing my own apnea monitor and scales. I realized that this was not what my baby needed and that I needed help. So I joined a mother's group where I was supported to share my anxieties, move forwards, and trust myself. I look back and I can see the positive effects that this support had for our family in the short and long term. We know that families want to and should play an active and central role in the care of their babies, but that, like I did, many feel ill-equipped to care for their preterm or low birth weight infant. They may have gone through a difficult or unexpected birth, full of anxiety and fear, to be then thrust into the bewildering environment of an intensive or special care baby unit, with new terminologies to learn, new routines to get used to, and with perhaps clinical ups and downs too. This may all happen along with the stress of trying to maintain family or financial commitments outside of the facility. Discharge, when it comes, can be a mix of excitement and apprehension, with families unsure what life with their baby may be like outside the facility. Families need to be supported through this journey, with evidence that support can increase weight, length, and neurodevelopment, improve maternal-child interactions and breastfeeding, and reduce maternal anxiety. We have the potential and capabilities to improve the support provided to families in the facility and at home. In the long term, this needs commitment and concerted actions from political and programme leaders, dedicated funding, as well as the development of standardised training, supervision and monitoring packages. But in the short term, we can all think about how best we can use these new guidelines to support families within our local contexts, through education and counselling, peer support and discharge planning. The inclusion of these interventions in the guidelines is a great first step to providing the support that we know matters to families, will help them be empowered and involved, and can improve outcomes. Thank you very much.
Zilli, thank you. You've given us a much better idea of what the recommendation on family support really means and what it requires. Well, we've heard from our panelists about a number of the recommendations among the 25 that have been made through an extremely rigorous process. We focused on the strong ones here today, but there's a number of other ones. There's some that were updated, there's some additional new ones, and we invite you to read about them and to review their use in the new WHO guidelines that were published this week. Taken together, these recommendations have tremendous potential to improve the care, the survival, the health, the well-being of preterm or low birth weight infants in communities and in hospitals throughout the world. These recommendations will also go a long way to ensuring that families are put at the center of caring for their baby, and that the families receive the support that they need to play this role. In addition to the importance of these new recommendations, we've also heard some thoughts on how the implementation of these interventions can be taken forward and some of the challenges that need to be addressed and overcome yet. Many of these recommendations can be implemented pretty readily in homes, clinics, hospitals throughout the world. We need to make sure that families know about the benefits of these practices and that we work to remove the barriers to their practice. For example, parental leave and entitlements, and supportive measures like education, counseling, peer support, discharge planning, and home visits. Now, some of the recommendations are going to require more fundamental shifts, like the provision of immediate KMC when we're talking about unstable babies in intensive care units, the provision of high-quality CPAP, and costly medications like caffeine. And here we need innovations in policy, infrastructure, workforce, service delivery, financing, and measurement. As a global community, it's time for us to come around these recommendations. We have an imperative to prioritize the care of preterm or low birth weight infants as called for in these recommendations. I just want to give a special thanks to our panelists. They are a group among a larger group of guideline development members, 25 of us who worked together for well over a year to develop these recommendations. It was a tremendous joy an honor for me to work with this group. Thank you to WHO. Thank you to my colleagues. I learned a tremendous amount and very proud of taking these recommendations forward. Thank you.
Thanks very much to Gary and the panelists for this really exciting but also, important reality check on about our new guidelines and particularly about their implementation. So thanks so much again to the whole panel. We would like to move on now. We're now at the final stage of our webinar, which is all about implementation. And particularly, we wanted to focus on how WHO, together with all the partners, especially UNICEF, how we will be moving on to implement these guidelines. So I'd first like to introduce Dr. Rajesh Mehta, who is now a consultant for our MCA department and who was until very recently the regional advisor for newborn child and adolescent health at WHO's Southeast Asia Regional Office. So over to you, Rajesh, to talk about plans for WHO implementation.
Yeah, thank you. Thank you, Karen, and good evening. Greetings from New Delhi. So now over to how do we translate these recommendations and other newborn recommendations into evidence-based practices where the healthcare team comes in contact with the newborn and the families. So it is very clear that we have to incorporate these recommendations as much as the recent newborn recommendations, like the use of antenatal corticosteroids, all of them into care of small babies in close partnership with families and at all levels of care, from home to first level and referral level health facilities. At present, in our work stream, we are particularly focused at inpatient care of small or sick newborn babies in level 2 facilities in district settings. As this is the next frontier in accelerating newborn mortality reduction and also ensuring better quality of life after survival so that these babies thrive equally well in the SDG efforts of the global community. To this end, WHO is working with UNICEF and ENAP partners, as Karen just mentioned, to develop guidance on content of care and scaling up of care for small or sick newborns based on the WHO standards and the guidelines and recommendations as the most recent one about which we heard today. So I will briefly describe the key actions being undertaken for this implementation through a very consultative process with partners and experts. Next slide, please. So today, together with UNICEF, WHO is in the process of developing an implementation guide, and Gagan had mentioned this as an important requirement by the countries for scaling up level 2 inpatient care for smaller sick newborns based on the 10 health system oriented components and the contents of care which were identified through a consultation, global consultation on smaller sick newborn care in December 2021, where we had the opportunity to listen to 500 stakeholders and 42 countries sharing their experiences of implementing smaller sick newborn care in health facilities. This implementation guide will assist the countries to plan and make progress towards achieving the ENAP coverage target 4, that is 80% of districts in these countries to have a level 2 newborn care unit, including the CPAP, which was so beautifully explained by Professor Shoaidullah just before this. For this scale-up guide, we also need to undertake evidence review for setting the norms of the number of special newborn care units needed in relation to population in a district, required infrastructure, especially when Suman Rao said that we need to bring the mothers inside for longer duration along with the baby in these units for IKMC and any KMC. And therefore the staffing pattern essential equipment, and now with CPAP and the safe oxygen delivery, and also essential medicines, including methylxanthine, the caffeine, which we just discussed, and other standard provisions of infection prevention and control, etc. We are also developing learning resources for healthcare teams for level 2 small or sick newborn care in district settings. These will, of course, include the preterm low birth weight guidelines, which have been launched, which have been described in this webinar today, to support healthcare teams to partner with families and parents in providing good quality care. This will also include continuous quality improvement processes and a supportive supervision approach to ensure that the compliance to evidence-based recommendations is around 100%. WHO and UNICEF are also finalizing maternal newborn health indicators along with other partners, including the ones related to the preterm low birth weight care within the global monitor and the comprehensive emergency obstetric newborn care frameworks, which are being updated. These indicators would be embedded in the national and district health information systems and will help monitor the implementation at national, subnational level, but also countries would report globally the progress in care of small and sick newborn, small or sick newborn. Next slide, please, Karen. And based on these preterm care recommendations and the other recent recommendations of newborn care, we are also updating the existing WHO technical products and tools like IMCI shown here, the chart booklets, the WHO Pocket Book of Hospital Care of Children, which is quite popular, and the WHO KMC Practice Guide, about which you will hear a little more in the next section, and home-based care, etc. Next slide, please. And similarly, we also would support updating of regional and national technical products and tools, some of which are shown here from different regions and countries of the world. And please note finally that there will be an ongoing process of monitoring and evaluation with the view to update these recommendations and other recent newborn recommendations maybe in 5 years' time. So that's how we are preparing ourselves to assist countries to implement at scale these recommendations and overall small or sick newborn care in district settings to accelerate mortality reduction and improving quality of survival. Thank you all, and back to Karen.
Thank you very much, Dr. Mehta, for such a clear presentation. We felt it was very important to have also present on specific example of one of our major recommendations, kangaroo mother care. So it's my great delight to be able to introduce Dr. Sujita Gupta, who's medical officer with both our WHO department here at headquarters and also the WHO Southeast Asia Regional Office. So over to you, Dr. Sujita. Thank you.
Yeah, thanks, Karen, and good day, everyone. So we have heard how the current guidelines would be incorporated in the resource materials for small and sick newborn care and other technical products. But as alluded to by several panelists, certain recommendations may not be easy to implement and scale, even after these are incorporated into the country-level policies and guidelines. Kangaroo mother care, or KMC, is a typical example. WHO has long been strongly recommending KMC, but still the programmatic implementation remains very low. Therefore, last year, WHO convened a global multi-stakeholders working group on KMC. It comprised country program managers, UN agencies, bilateral development and other specialized agencies, donor foundations, professional organizations, parent bodies, researchers and scientists, and many more. And together, we have prepared 2 documents. The first is a global position paper, which summarizes the evidence and strategies for implementing KMC as part of the national maternal and newborn health programs. And the second is an implementation strategy for scale-up that can be adapted to the different country contexts. This strategy describes how KMC can be implemented at different levels of care. That is, in secondary and tertiary care facilities as part of the small or sick newborn care, in primary care facilities as part of the essential newborn care, and also at home. WHO is also updating the KMC practice guide, which was last released in 2003, which will serve as the operational guide for healthcare workers who are practicing KMC at all levels of care. Now, all these documents are in the phase of development and should be available by early next year. Now, this update is not only for your information, but also to highlight the fact that special efforts might be required to implement and scale at least some of the new recommendations in different contexts. And this is something that we all need to consider and prioritize and implement these guidelines based on our setting. With this note, I thank you and hand over to Karen for further facilitation. Over to you, Karen. Thank you.
Thank you very much, Dr. Sachita, and thank you again to Dr. Mehta for really describing so well how WHO is planning to implement the guidelines. So with just a final note of thanks to all the speakers for such clear presentations, I'd now like to hand back to Dr. Anshu Banerjee for closing remarks. Thank you very much, Dr. Anshu.
Thank you very much, Karen, and thank you to all the speakers today for telling us so powerfully how the recommendations really can positively impact on babies, their families, and health services. And I think one of the things we've seen is that the guidelines really make recommendations to bring interventions closer to families and babies, as well as start them much earlier on. So it's exciting to have all this evidence together in one place, and we feel that there's rigorous implementation, of the WHO recommendations could transform maternal and newborn healthcare delivery across not only low-income countries, but also middle and high-income countries, and have an important effect on the survival, health, and long-term developmental and educational outcomes for those vulnerable preterm and low birth weight infants. We look forward to your comments, and I've seen that there has been a very interactive discussion on the chat, and also to suggestions on how we can go on this journey together. Maybe, Karen, we can have the slides up with the links that we have and the other kind of documents that we have. And you can see here on the slide the WHO website links to recommendations. We encourage you to download the documents. We'll also share the presentation so that you can click on these links and download the documents and disseminate them, and most importantly, of course, to use them yourselves to help to improve the care of preterm and low birth weight babies. The next slide has also got some additional resources. And just a quick overview, and we would like to thank you once again for your attendance. I think there's one more slide. No, Karen? Yes, to continue the discussion, these are ways that we can continue the discussion on how to implement these recommendations. And we'd like to thank you all once again for your attendance and best wishes. We had, I think, at our peak, over 900 people who attended the webinar. So this is already wonderful as part of our dissemination of these guidelines. And we hope that all of you will at least send it to 10 other people who will send it on to 10 other people, etc. Thank you all for joining us today, and have a good day.
Thanks to everyone.
Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you.
Thanks. Yeah. Thanks
Great
very
job,
much.
Anna. That was amazing.